Welcome to AWAC Services monthly educational webinar series. This educational series is offered on the third Thursday of most months at 2 p.m. Eastern Time. This month's title is Emergency Medicine, Top Areas of Litigation. Please note that a PDF of this presentation was sent to you as an email attachment to the email address you provided at registration. If you do not receive it and wish to receive a copy, please send a request to riskmanagement@awacservices.com. All have been placed on mute. If you need assistance during the presentation, please click on Host in the chat room feature of the WebEx, and you'll be able to send a message directly to me or call 860-284-1450 for assistance. This information is provided as a risk management resource for Allied World policyholders and should not be construed as legal, technical, or clinical advice. This information may refer to specific local regulatory or legal issues that may not be relevant to your organization. Consult professional advisors or legal counsel for guidance on issues specific to your organization. This material may not be reproduced or distributed without the express written permission of Allied World Assurance Company Holdings. Management services are provided by or arranged through AWAC Services, a member company of Allied World. Our speaker today is Dr. Robert Bitterman. Dr. Bitterman earned his medical degree from Wayne State University and his law degree from the University of Detroit. He completed an emergency medicine residency at the University of Cincinnati and practiced emergency medicine for over 30 years. Dr. Bitterman is an active member of the State Bar of North Carolina. Currently, he is president and CEO of Bitterman Health Law Consulting Group, a health law and consulting firm specializing in federal law governing hospital-based emergency services, emergency medicine, risk management, liability and insurance issues, and regulatory compliance issues. Most recently, he was the chairman and CEO of the Emergency Physicians Insurance Company, a risk retention group based in Sacramento, California, and the director of risk management for the Emergency Department and Residency Program for the Carolinas Healthcare System in Charlotte, North Carolina. Dr. Bitterman is a board member of Emergency Medicine Patient Safety Foundation, a contributing editor to the Emergency Department Legal Letter, and its editorial board, out of the Emergency Department Management Letter. He is also a member and immediate past president of the American College of Emergency Medicine Medical Legal Committee. Dr. Bitterman serves as a consultant to ACEPT and other healthcare organizations, hospitals, review organizations, and law firms throughout the country on EMTALA and ED legal and risk management issues. Bitterman is frequently invited to speak at national conferences and has published extensively on EMTALA, state laws, risk management, and administrative issues concerning emergency medicine. Dr. Bitterman authored the widely used text on EMTALA, providing emergency care under federal law, EMTALA. It's my pleasure to turn the program over to Dr. Bitterman.
Hey everyone, I hope you can hear everybody fine. Thank you, Pauline. It's a pleasure to be here. We'll start with the slides, and I'll make reference to the slide numbers occasionally, so you're on the same ballpark as I am. This came from a French who basically a good analogy for plaintiff's attorneys who can be very creative for going after us in emergency medicine. So some need to be as imaginative and as committed to preventing malpractice as are in terms of coming after us and for protecting us from unnecessary litigation. Next today is we're going to talk about prevention. What are the top areas is the ED regulation? Why do EDs get sued? Right? But the approach is going to be more risk management centered. What can managers do to change the litigation profile of the ED? Actually decrease the number of claims coming out of your emergency department. opposed to what can an individual physician do in their own specific individual practices to try to prevent risk. That's another topic for another day. More be consists of what an organizational can do on the ED risk profile. We'll talk specific high-risk scenarios, particularly chest pain and belly pain presentations. But what's words about others such as headache, blood pressure, back pain, and what we call high-risk encounters, issues of the hospital, such as radiology against medical advice, and sort of a gray area related to emergency medicine. That's the use of mid-level providers. But the goal here is to prevent claims in the first place. The whole aim of the game is to stay out of the game. Because anybody who's been in the game knows once you're sued, the whole system sort of tumbles through its unended consequences in course, and you're just stuck in the game, and nobody really wins in the end, even if you happen to win a trial. Next slide. Give you some information and data, and this comes from a whole different sources. National Practitioner Data Bank. It's a physician-owned insurance companies of America, and they produce a nice document every year on litigation claims arising out of emergency departments, and it's a very good summary of things. Insurance companies, Epic is the one I work with for a long time, which is a specific insurance company, and there's a host of data on this. So we have very reliable data of why EDs and emergency physicians get sued for malpractice. This stuff is entirely predictable, and it's also entirely preventable. Okay? Next. Are we high-risk practice? You bet we are. The ED is the #1 source of hospital litigation. Okay? And I suggest to you that no one wins. Everybody loses in the end game. Next slide. You can go on to the next one. Claims really depends on geography. The average nationally is about 1 in 20 to 25,000 ED visits. But if you're Dakota, it's 1 in 125,000 visits. And South Miami, South Florida, it's 3,500 to 4,500 visits. So a lot of geography. I don't think the malpractice is any difference in those two geographic areas. 60% of the time, they go away with no indemnity payment. 30% of the time, they go away with some indemnity payment. 5% go to the trial, and we win, quote, and win 80% of those that go to trial. Good, but you don't go there in the first place. The matter is only about 45 or 50% of the money actually ends up in the hands of the plaintiffs eventually, or it's turned up in the system. Attorneys, experts, court costs. This is a really inefficient compensation system. Next. What is management? This is my perspective on what it is. It's a process to go through to identify and try to eliminate or minimize risks. Effective. You ought to be thinking about this stuff before you go to work. You want to get ahead of it rather than react after the fact when you have an adverse outcome or an investigation that says you did something funny or wrong. And what you really want to do is not leave this stuff to individual physician variation. You want an institutional attack or approach, like we do with pain bundles, stroke teams, test bundles, things like this that you think about institutionally. You reach it down an individual physician variation to cover your risk. Now, the thing about this is you've got to know why you're getting sued. All right. Actually, no. This is a rhetorical question because you can't raise your hand on the webinar here. Is what time of day do malpractice claims? What happens is 60% of these occur between 6 p.m. and 1 a.m. on weekends and holidays, and another 20% occur on the midnight shift. So when you think deeply about it, it kind of makes sense. You have the busiest times, the easiest mistakes. You have the least available ancillary staffing. We staff this at the times with the least experienced physicians. You're the rookie, you work nights. You're the rookie nurse, you work nights. We don't work 12-hour shifts on weekends. We probably shouldn't. They should be working 8-hour shifts. At least one change of shift, and then you got circadian rhythm problems. So that's when you have high-risk issues. Maybe you should change things. not least experienced people. Please couple them with one of the more experienced and staffing levels, 12-hour shifts, etc. So a bunch of these things, 50% of claims occur systems issues. Things like handoffs, radiology, labs, mid-level providers, protocols, procedures, documentation. That really has to do with the individual physician judgment as it relates to that case. So in your particular settings, bore down, find out where you are losing your money, and spend your time and effort trying to figure it out and work there. So you got time and energy on this. Next. Truth in the fact that experience, expertise, and medical skill really do matter to avoiding risk. After all, the number one cause of malpractice litigation is malpractice. No doubt about it. We like to think that it's not, but it really is. So you invest in your brightest at the right times, long hours, middle of the night, that sort of thing. So you want expertise really does matter. Next slide. But in emergency medicine, and this is probably true in all of medicine, that practice medicine, good medicine, is not enough. If we look at these cases retrospectively with just an objective eye, only 20% of the time when doctors and hospitals are sued for the emergency department do we actually find real negligence. The other percent of the time, the reason the suit was filed in the first place had more to do with how that care was provided rather than the quality of care that was provided. It boiled down to basic human failure to meet expectations, communication skills, lack of interpersonal skills. Tell me anything. They were rude. They ignored me. They didn't explain what was wrong. They wouldn't let me go back to see my mother. This is what I call the behavioral aspects of medicine, literally where 80% of all the claims arise. So this human interaction makes an enormous difference in emergency medicine. Another where we get sued a lot is fail to follow your own rules. Things like joint hospital policies and procedures, care contracts if you happen to be in high penetrated managed care areas, and follow state and federal laws like EMTALA. If you say all patients will be medically screened and seen by a physician within 30 minutes, and you fail to do that, you follow your own standards, fail the federal law, and you set yourself up for litigation. Anything policies and procedures, and we'll come back to this a little bit, be very careful how these are written so that you don't box yourself. You don't put something down that you can't do on an everyday, every patient basis. From a diagnostic perspective, or medicine perspective, we get in trouble basically because we failed to diagnose things. You acute MI in the chest pain patient. You miss sepsis in the child with high fever. You miss PE in the 20-year-old who's got belly pain. Those kind of things. Right? And by far, the most common, most costly, and most dangerous errors in medicine. Slide. In the categories of these patients who present, wounds are very high up there on the incidence of malpractice claims. Check on a third, then belly pain. Next slide. But then where the money is lost, chest pain is the highest by far and away. All right? Simply because of their numbers, the pain increases and things like intracranial hemorrhage are head patients that we miss subarachnoid hemorrhage, and then the peds, fever, meningitis, sepsis cases are, again, big money dollars. Right? So this for decades in emergency medicine, and so this ought to spend most of your time and energy trying to prevent claims in the emergency department. Behavioral histories, I just want to say a couple things about this because this has to do with what the damages someone has. Talk to reinsurers, they always want to know what are the damages, what are the damages. Because that baby who's there in the courtroom, that more due to influence the outcome of the case than was negligence or non-negligence. Okay? Now, people need motivation to sue you. They need motivation, anger, coupled with outcomes. All right? Is not meeting their expectations. Perceived expectations, whether they're real or unreal, patients, they don't know if you're a good doctor or a bad doctor, but they know how they were taken care of. We used to them. That sort of thing. It makes an enormous difference. And in medicine, what I call jousting is 20-25% of all cases in emergency medicine is directly related to another caregiver saying, we screwed up in the emergency department. The orthopedic surgeon says, pick up this x-ray, or they didn't read this x-ray right in the ED, or you go to general surgeon and say, do antibiotics for this? It's just body language. But people criticizing us, it creates litigation. You on top of it. You got to make an appointment, sit in their office. Hey, here's how you say things. You wear, time changes disease, you don't know. Give us the benefit of the doubt, because you don't really know what went on in that emergency department. So that's work. So a behavioral thing, risk management actions, things that you can get involved in, is attitude at the top. This stuff circulates down. You're getting good people with good attitude, good leadership skills, and have zero tolerance. People who can't communicate well, don't treat people right. These sort of behavioral type problem physicians that generate 80% of your malpractice. Spend another couple hours on this issue, but this is a big deal to preventing malpractice in emergency medicine. Next slide. A little bit more today about high-risk clinical situations. We can divide those into high-risk complaints, that's your chest pain, belly pain, etc., high-risk encounters, systems, radiology, etc. Risk complaints, there's no question that chest pain is where you ought to spend all your time. If anybody could solve anything in the ED, it would be the chest pain rule out MA problem. And we'll spend more time on some of the others as well. So we spend time on chest pain because that's how the money is. That's why the Sutton Law was, why do you rob banks? Because that's where the money is. 8 people come to the ED every year for chest pain. One of the most common complaints we see. Lethality, they a lot, and high degree of awards. Right? Whereas 30% of ED cases end up in some indemnity payment. 30% is the number I gave you earlier. 60% of chest pain patients end up paying some amount of money out. The amount of money go out is usually 2 to 3 times higher than the average amount of money that goes out for all the other claims. Where the money is, where you spend tons of time. Now, it's just atypical. It's weird. It's odd. That's what we missed. Turns not true at all. Most of these patients, vast majority of these patients, walked to triage and said, I'm having chest pain. They may not have said I'm having crushing substernal, high-type pressure chest pain, but they said having chest pain of some kind. You weren't on notice that they were having chest pain. Okay. You missed this. Well, we're very good at figuring out what kind of chest pain is cardiac chest pain. No matter cardiologist and emergency physician tells you can figure it out, taking a history about the pain, that kind of pain, care, how often, how frequent. Turns that's a myth. Right? Study after study shown that doctors are no good at figuring out who has cardiac pain and who does not have cardiac pain. And burning pain we associate with esophagitis. Turns out 40% of people who have a myocardial infarction bring a burning pain exactly like esophageal pain. The 20% of people figure out complaining of pain that's unusual. Oh, it's dull, achy, lasts for seconds, lasts for minutes, go my shoulder, my jaw, my back, whatever. It's weird. But it's chest pain. About 10 to 20% of those patients have a myocardial infarction. Truth is, the character of the pain, the nature of the pain, not diagnostic. And you need to get over that. Young to come out of residency medical school, they think they can figure this out. Seasoned old-time physicians, those who've got lots of gray hair, have learned by experience that it simply isn't true. Okay? So the reality is this atypical description of the pain, not the fact that they have pain or not, is very common. Sure, some patients, particularly old patients, come in with belly pain or come in with no pain, diabetics, etc. But those are the typical cases that we get sued for. Yes, it happens, but it's not the big ones. It really isn't. People think is they think they can figure out by bedside maneuvers. You push a chest. Oh, they've got chest wall tenderness. It's not cardiac. 40% of the patients with a diagnosed MI had reducible chest wall pain tenderness in the emergency department. Okay? It is diagnostic. Can't rely on that. Anything with GI cocktails. The majority of patients with chest pain will feel better with a GI cocktail. Some will get entirely better. It's diagnostic. You can't rely on those bedside numbers to who and who does not have EKG, who does not have cardiac ischemia. So that's the reason we get sued. We just understand that. We don't fail to accept that as caregivers. 75% of the time, chest pain, acute is missed in ED, is doctors just misread the EKG. Or they don't make the effort and get an old EKG to compare it, which shown that the one today was different than the one they had last month or last year, that kind of thing. So your old EKGs are available on a real-time basis to the ED, 24/7, 365, on an immediate basis. Of the time is people don't understand biomarkers. If you order a set of enzymes, you get another set in 8 to 12 hours because the number may not be such that it's maximally evident until that period of time after the last episode of chest pain. Other to this, low normal EKG, and it's been at least 6 hours after the pain has ceased, and you have high sensitive troponin testing, that's pretty good, right? But by you order one test, you ought to get a repeat test at some period of time, 6, 8, 12 hours later. It recommends 8 to 12 hours. Cardiologist anywhere from 6 to 12 hours. All right? Because you need to keep people around for a while. We need to send them home too quick. We have chest pain units. We don't have observation areas. Or we stress testing before they go home. All right? We'll talk about that in just a second. And more than one EKG. Studies have shown repeating EKGs. People with acute MI walk into the ED with a normal EKG, but it may be normal for 2 to 4 hours later. We did it in the emergency department. Slide. In trouble. Step ahead is discharge instructions. Off your heart, it's okay to go home. Don't tell them that. You don't know that. In fact, sending them home for a workup, say specifically, look, we don't think it is right now, but you need follow-up because you don't want to pay to their doctor, and the doctor say, oh, they worked it up, it's not your heart and ED, I won't bother checking that, we'll go on and check other things. That's sick if you do stress testing and go through the whole rigmarole. Okay? And if you send someone home who presented with chest pain, with unshaded diagnostic chest pain, you know what it is, and you send them home, a very scary 20% of them will be diagnosed with a cardiac ischemia in the next 30 days. That's a very concerning statistic. So it means before you send them home with undifferentiated diagnostic chest pain, I think you should be able to do that. You prove their chest pain is something. Otherwise, you've got to rule out a cardiac etiology with some sort of testing in the ED. Biomarkers, repeat EKG, stress testing. Tell it something like pneumonia, shingles, no thorax, broken ribs, gunshot wound to the chest. If you don't have a reason for their chest pain, I suggest to you it's cardiac. That prove otherwise, and prove otherwise to a reasonable degree of certainty with some sort of workup, some sort of protocols next to you would to use as I call low-risk chest pain protocol. The whole high-risk patients you're just going to admit. But these off cases where you don't really know what's going on, you don't think it's cardiac, but you really have a reason for it. You have some sort of implemented, institutionalized low-risk chest pain protocol. There's the amount in the literature, whether it's a 12-hour, 2-hour delta test. What I'm getting at is a system that you and your cardiologist work together with the cardiology, work system that you can do some sort of protocol to work up these patients quickly in the ED or in an ICU unit before you send them home with, quote, undifferentiated or, quote, atypical chest pain. Those are dangerous diagnoses to send people home, particularly if they haven't been worked up yet. Okay. Chest pain, if you can do this, and not every hospital can obviously do this, but you can set up a chest pain unit where you can send patients to do workup and get stress testing before they go home. Your risk of missed is tenfold. We miss 2 to 4% in the general EDs. They miss 0.2 to 0.4% in a chest pain kind of unit. It's a big difference if you do something like this along the way. I'm on the belly pain. I'll move along here. Pain is the number one complaint in the emergency department. But I would suggest to you that it's notoriously slow to reach true nature. You have huge time in the department. Don't be quick to send these patients home. Disease changes over time. I happen to think the growth use EBC in the emergency department is of time it keeps them in the emergency department. All right, to be re-examined. Next. So, patients. Okay, slide 27 right now. Next slide.
There you go.
There you go. Thanks. Don't let them out. You don't know what's wrong. Get a consult. Have some help. Order more tests. Keep a little longer. Okay? What was your favorite uncle? So use time. Don't be quick. Let them go. It's allied to taking care of belly pain. And both folks are different. Next slide. Folks, the biggest thing we worry about is rheumatoid appendicitis. I suggest to you, you should never get sued for rheumatoid appendicitis. Think about it. It's on the belly, except you as the emergency physician. You're an emergency physician. How experts say, oh, they had an obvious acute abdomen. They had obvious appendicitis when he didn't lay hands on the patient. Getting appendicitis, missed appendicitis, is a failure of communications, documentations, and discharge instructions. If you evaluated patients and communicated to the patients, look, watch you for a few hours. They don't think it's your appendix now, but here's what to look for, and we need to check you back in 8 to 12 hours because we're still concerned about it. This could be early appendicitis. All right? You can't. Right? You've set expectations. They know they could still appendicitis. You haven't said, hey, there's nothing wrong here. Quote, it's just a virus. Don't do that. Yeah, here's what to look for. It comes presents this way, but if you get worse, it moves down your right lower quadrant, more fever, more vomiting, you come back. Otherwise, we'll see you tomorrow morning here in the emergency department or with their doctor in follow-up. You want concrete follow-up instructions. Not, hey, you get worse, come back kind of thing. Sure, okay, but we'll see you in 12 hours. If they get better, they come back. If they get, then they've got a system, you're in the system, and you'll be able to take care of it. That's appendicitis or potential appendicitis. Right? Are entirely different. Young, we never figure out what's going on the vast majority of the time. The pain just goes away, and that's the end of it, and that's the way it's supposed to work. Literally, over half the time, they end up getting admitted, and 34% come straight to the operating room. Right? In the elderly, it's a lethal disease. And I was a scary statistic. And I present to your emergency department with one complaint, belly pain. High mortality rate in the next 72 hours greater than the pain you have in the back of the ED with a diagnosed acute inferior infarct or anterior infarct, whose process is being cared for in your emergency department. We all over the patient, we have a known diagnosis of an MI. We let a 65-year-old belly pain sit out in our waiting room. Think about that. If you got 2 or 3 of them sitting out in your waiting room for a couple hours, very high mortality rate. Okay? 9 to 10 times higher than younger folks. And if you miss diagnosis, if you didn't make a diagnosis, you double that mortality rate yet again. All right? An entirely different approach on old folks. These are extensive. Do you know what's causing their belly pain? Get an EKG. It might be a heart attack in the old folks. get more tests, get a CT scan, get a surgeon involved. Right? If you're any kind of big size ED, you ought to be able to do bedside ultrasound. They have a aneurysm, right? See an aneurysm. Keep your minimum more, and follow them up closely. It's not see your doctor in 3 days. We'll see you in 12 hours. So for pain, from your risk management perspective, I think anybody who comes in with belly pain, they have their initial exam, and before they go home, at least they have to have one more reevaluation in the record before they go home. I can't send them home with vague discharge instructions. It must be you have definitive follow-up instructions in 12 to 24 hours. Concrete, okay? I'll talk about radiology here in a minute. Answer to this. Look at belly pain charts. Is there re-examinations documented? Is there follow-up instructions in a specific time frame for follow-up? If there's, fix it. Next slide. I'm going to say a few words about headache. Every chart ought to have on there these things ruled out, at least a chart, because they can kill people. The next 12, 24 hours, you send them home. Meningitis, subarachnoid hemorrhage, oxide intoxication, particularly in time, northern climates, and increase in cranial pressure. So at the stars in the chart, you as a risk manager should be able to look at that chart, and there's evidence in the chart that reflects they thought about and ruled, at least in their minds, these processes. No carbon monoxide exposure looked at. Fundoscopic exam ought to be in every chart for headache looking for increase in the cranial pressure. Okay? If you think, just review charts, quote, diagnosis of migraine headache, right? Because all these things most commonly get misdiagnosed as. But something ought to be on every headache chart. Okay? Next slide. Specifically about subarachnoid hemorrhage, because that's a big one. All right. Litigation. 8 people walk into the ED with headache every year. 30,000, that tiny percentage, end up with subarachnoid hemorrhage. But it's missed 10 to 20% of time on their first visit to the ED. That's a lot. And it's a lot. And he thinks, if it's not the worst headache of their life, it can't possibly be subarachnoid hemorrhage. That's a fallacy. If I give pain medicine, it goes away, it can't be subarachnoid hemorrhage. Compazine, it goes away, and that fallacy. Those are myths. It's often the worst headache of the life, but sometimes they say it differently. I've had migraines before, but I've never had one like this. It's longer. It's different in character. Associated symptoms. An episode of a brief seizure, or not got neck pain. You got to tease out the history, and these are things you need to look at on a chart to make sure that they have done this. So get a CT scan to rule out subarachnoid hemorrhage. The 25% of the error rate is we didn't think about it, we didn't get good enough history in physical, and didn't get a CAT scan. 5% is the way to realize that the CAT scan isn't 100%. Sitting there, it's actually quite good, these newer generation CAT scans, particularly if done in the first 6 hours, but it's never percent. So anything on the chart, headache, rule out SAH, rule out intracranial hemorrhage, and in the chart is a lumbar puncture. Lumbar puncture, you see an AMA form is saying the patient refused lumbar puncture. We miss a certain percentage of subarachnoid hemorrhage by not doing the lumbar puncture. So it's just a rule. You got to see that it's there, and don't just say, quote, I offered the CT, that's hunk, bull. You recommend it. If they refuse it, you write it down. Go home and die. And so they're real. Next page. Next. Couple about, skip that, I already said that. Next slide. 30, please. There you go. Pain, 2 things we miss on back pain that get us sued a lot: aneurysm and spinal cord compression. So that comes with back pain, ought to have a belly pain exam and a complete neurologic exam every single time. Even if it's that chronic back pain patient you've seen for decades, all right, this would be the time his disc is moved and now a cord compression syndrome, what we call our equine. So from a risk perspective, every back pain chart ought to have a belly exam and look at the complete neurologic exam. And if you have back pain, you'll be able to do a bedside ultrasound to rule out aneurysm thing to have as well. Next chart, next case. Okay. Someone's got back pain. The neurologic symptoms you ought to be looking for are here. Not tingling, bowel or bladder symptoms. They can walk. Patient walk right, go home. It's that simple, unless you can prove why they can't walk right. Bullet hole in your knee. Okay, I understand that. But if they say I can't walk right, and you say, yeah, you've had this trouble before, you go home. You better watch them walk. Or you'll watch them walk in trial, or can't walk at trial. Next. So to believe patients, high litigation, those are expensive errors, right? But is home with back pain, ought to go home with instructions on what to look for cauda equina, because we have to disc disease. 2% of disc disease ultimately ends up with a cauda equina syndrome. Right? Neurodepression of the cord. We have to be. These are true neurologic emergencies. You got an MRI quickly. You got to be able to get neurosurgically quickly. And so you tell these people, this is what you look for. And that's what you ought to see in the discharge instructions. Look for tingling, bowel or bladder problems, or change in perianal sensation, etc. Trouble with that, you need to come back, and that has to be on the record. Slide, please. All right, slide. Sort of said that already. Time-wise, I'm good. I think I'm right on the money here. Fractures for body, not a money deal, all right? But this is another one of these things that you really shouldn't get sued for ever, right? If it's an X-ray, you got to go home with a splint. So if it does better, you got time for the radiologist to review things, and they can follow up for that. It has to be explored for neurovascular tendon status. That's what NVT means. Foreign body tetanus status, and mechanism of injury. These are the things that ought to be in every chart that you ought to be looking for in a risk management perspective. Mechanism says high pressure injection injuries or fight bites. It's a human bite to the hand that got in the bar last night. These are very high risk injuries, and certain things ought to fall from that. This common thing for hand injuries, turns out well over half of those are readily apparent on a routine X-ray. If the patient has a hint of a foreign body, or if it's a broken glass, or something with a potential foreign body, you ought to get an X-ray. Hand injuries won't even come into the ED for in-hand unless you've got an X-ray. They don't care what it costs, but they want an X-ray to know what's going on in there. You ought to be liberal with X-rays looking for foreign bodies. Antibiotics. Not everybody needs antibiotics. What you do is set expectations. Here's a wound. We cleaned it up real well. Look for foreign body. I'm not putting now, but if it gets infected, come back, we'll do this. So they go to somebody else. They don't say, I mean, that emergency physician didn't put you on antibiotics. Answer to that. Talk to me about it. He explained why he wouldn't, but he would if I got infected. Set this expectation. Don't say there's no foreign body for sure. Say, look, we can't find anything right now, but here's what to look for. If you notice Y or Z, then take another look again. These things are failures of discharge instructions and follow-ups again. Okay. Next. High-risk encounters a little bit. These we'll talk about a little bit. Next slide, if you would. I just had when you're waiting. What's the number one complaint against the emergency department? Waiting time. Things about this. Patients leave before exam because they've been waiting a really long time. The longer they wait, the more hostile they get. The likely they are to sue you. And you should track these so you know busy time, etc. People leave before exam. What half of the time is, they document that, then they throw the chart in the bin that goes off the medical records. I suggest you someone should look at that in real time. Sniffles, 2 weeks, normal vital signs, fine, throw it back in the bin. But one 20-year-old, temperature 102, heart rate 120, status splenectomy, that guy has got sepsis. He's going to die in the next 40 hours if you don't get him back. So from a management perspective, good care perspective, someone ought to look at these in real time and make sure there's nothing there that you now have knowledge of now that is really you ought to be sending the cops out to the house to get the patient, bring them back. What I want to say about AMA today is you ought to track this per physician. All right, this is a failure of physician communication skills. There are physicians that nobody ever goes AMA. There are physicians where they go AMA all the time. All right, you got to know this. And all right, this is an attitude problem. If you have attitude, you fix the problem by firing them. Go AMA, sue the hospital 30 times more frequently than other patients. They are at risk. And coupled with adverse outcome. You've already angered. They already told you they don't trust you in your care. And you told them they're going to have an adverse outcome if they go away. All right? So, whack a hawk. And this is a physician communication interpersonal skill problem you need to deal with. Next slide. Radiology. Anybody who knows me knows I got a bug in my butt about radiology. And the reason this has been a problem for litigation against emergency physicians since the day of practice in 1976. It's a problem that we should never have anymore. Right? We don't have the guts, basically, to get the right film, right radiologist at the right time. Right? To you today, fellow radiology and the expertise we have, if you can CT scan for subarachnoid hemorrhage, that CT scan should be read by a board-certified neurologist with specific expertise in reading CAT scans to rule out subarachnoid hemorrhage, and they ought to get that back to you before the patient goes home. You can get that film anywhere in the world in real time. All right? If you don't want to do things in the night, send a radiologist to Italy and have the films at night from Italy. What do they do in Los Angeles? They send the radiologists to Italy and read them at night so the real-time interpretations to the emergency department. Two options is we send this patient home. It's read the time moon resident or one of the general radiologists who doesn't do head CT on a regular basis, and we call them back with sample film, and we can't reach them, we can't get them, or now they're dead. And people home with emergency physicians, yeah, we read L films, chest X-rays. We do things that kill them. Not get X-rays. If we find things that kill people, hemorrhage on a CT scan, perforation on a CT of the belly, or meningitis ischemia. So you things done in real time to make a big difference. If you can't do that, and I recognize you can't do that everywhere, then you use a system where you overread these films very quickly, right radiologists, and you have an ironclad variant system. Get information right back to the emergency department, and they can get that patient immediately to the patient. Okay. Talk about discharge instructions in a minute. Anytime you order an imaging study on a patient, one of the things you ought to do on the way out is, hey, look, we've got this study. So far it's negative. Your cell phone or a phone number that I can reach you tomorrow morning, where if you have an abnormality that we need to get a hold of you right away, that we can reach you. All right? How to do not just come on the reliability, the demographic people getting a phone number when they come in at front. But now, look, this is really important. Remember the problem, how can I get you tomorrow? You can't get them tomorrow. You can't find them. All right? They die. This is a big deal. Now, so you ought to work to get contemporaneous file readings of real imaging studies by the radiologist in real time. And you're in a cloud follow-up system if you don't. Okay? And after this, you got to make sure the radiologists are doing their part to help the emergency department avoid litigation, because this is a big area of litigation still today. Get emergency physicians and your emergency departments. But levels. 2 years ago, only 5% of patients were seen by mid-levels in the emergency department. Today, it's 40 to 60%. Only 15% of EDs use mid-level providers. Now it's close to 90% of EDs have mid-level providers. To you, that insurance data shows that has increased litigation against emergency departments and relative proportion to their numbers. What I'm saying to you is males are a higher risk in the department than chief physicians. And there's a reason for that. It depends on how the emergency department uses them. So, all rhetorical questions. Do you know in what capacity your ED uses mid-level providers? Here's the range of ways they do that. Some places function like residents. They go off patients, they send home if they want to, and they talk to when and if they think they need to. Some say they often see patients, they might talk to them about them, but they don't see them all. Some places they go see everyone. Okay? Some use them like real physician's assistants. The physician makes all the decisions. They get everybody, and then they say, oh, okay, this is a chest pain, he's admitted. They come back to the PA and say, may happen. They go, they examine the wound, they determine there's no neurovascular tendon compromise. Then they come back to the PA and say, go suture it up. Different modalities, different ways EDs use mid-level providers, and they have different risk profiles. So you look at that, address that, look at policies and their procedures, look at what they're credentialed to do, and then get that sort of tightened up in terms of how they work and function in your emergency department. What is the surgery system? Is the ED doctors there, or is it any one of the 3 ED doctors there? They're really assigned to one, so everybody knows at any one time who's supervising. Or if they're named licensed physician, up with the one who's responsible for them at all times. The one is crystal clear that everybody knows what it would be supervising the PA, right? Particularly hired by the hospital, paid by the hospital, and not an employee of the physician group. Right? Then you sort of dichotomy about who's responsible for whom. Okay? So you tighten that down real well. Okay, next. Shift handoff, dangerous time, not just for the patient, but for your relation. Everybody knows about communication errors, right? So the best is to have some sort of system where the physician knows what they're responsible for, what their duties are, and the lead physician knows what their responsibilities and their duties are. And I would suggest to you that the big reason there's litigation related to these is if an incoming physician fails to take ownership of that. You try to solve as minimally as possible. All said, it's fine, I just need to check this lab test and let them go. Or just look at X-ray and let them go. Or when the doc calls, I just need to tell them this and then they're done. To you, that's simply not good enough. You ought to have a rule where if you're a coming physician and you're going to be the one to end up discharging that patient, you see that patient and write a note on that patient that you have flavor, a good understanding of what's going on, and that didn't get missed. Particularly if you come a day shift. You know, night people, they just don't think right sometimes. Scrambled at night. So they're thinking they're giving you the right data, but you ought to walk in the room and check on it yourself. Do this. Bar. Methods. You know, some schools, you always stand in front of the screen. You make sure you go around the room. You catch every room. You don't want to miss anybody. Ways to do this. One suggestion is you make sure you address the issue. All right. Discharge instructions. I've already hinted at this, but these are really important. 80% of all emergency medicine malpractice cases are related to in some way or impacted in some degree by discharge instructions. This win or lose MCAL or EE-related malpractice cases. All right. Make sure the patients have specific and time-specific instructions. They understand what the issues are. They're told to come back at X hours. They told why it's important. They told you what you're looking for. Set expectations with your discharge instructions. Your secondary issues. You know, what else? Family. Whether it's communicable or disease or not. You know, you make a diagnosis of the disease. Got to make sure you tell them sex, because otherwise you put other people at risk. Lots of these secondary issues you need to address. Well, particularly if you're worried about or complicated things, I bring the entire family back from the waiting area. You want them to hear the same story. You want them and help in taking care of things. Just something, so the patient comes back and gets care. And they hear the story from you. Right? You tell the patient that, they're getting dressed, go out, they go out to the room. The family says, well, what's the doc say? Oh, nothing. All right? Bring them back, say, here's what we're looking for, here's why we're concerned about it, that sort of thing. Just add more people into it. From a risk management perspective, make sure you get their signature. That they discharge. Because they go later, what do they say you tell them? Oh, man, what do they tell you? Nothing. They never told me that. Of course you did. So if you charge instruction, you got their signature, you got a double presumption. All right. Indeed, now the onus is on them to prove that you didn't tell them all that stuff. I mentioned earlier about any of that X-rays, particularly high-risk imaging studies, make it a phone number in real time. Right? I would entirely on the demographic folks up front at registration. All right. I patient, when can I reach you? How can I reach you? If I have a problem, what it is. It's just because I wake up in the middle of the night and I say, hey, what's wrong? I need to call them back and make sure they get X, Y, or Z checked. Okay. And the last topic we're going to sort of hit today is emergency medicine areas of litigation without talking about documentation. Chart. Read like a storybook that comes to only one conclusion. That's what your emergency physician decided. You take a chart out to an outside expert, have him look at it. At the end of that sort of review of the chart, say, this is done. It turns out that's exactly what your physician would have done. Okay? Now, next slide. How do you tell a story with checkbox charts? How do you tell a story with electronic medical records? Cases, that's probably perfectly fine. Certain cases, any case, it's in the emergency department. Trauma cases that were there for 6 hours that you had to transfer to a major trauma center and things are going on or going wrong. You have to dictate sometimes on these complicated, high-risk, known, high litigation scenarios. Because 5 years later, when it goes to trial, you don't remember everything. You're on trial to some degree. Now, it's just to say, if there wasn't a chart, it wasn't done. That's hogwash. Lots of things that we did and we do at time, and we can introduce into evidence. Right. But large, you're able to have a story there that you can support what you did and your rationale and thinking behind it. Right. I suggest to you that there is a learned art. Not a medical student or residency and know how to document a chart for risk management purposes. It's your job. Teach them. Get medical directors to teach them how to say things, what lines to include, what to address, what not to say. Right? But this is something you spend some time on, figuring how to do that to avoid liability. All right? And next, the whole goal here is to avoid being named in the first place. The first thing they do is look at a record. There's voids there. They know how to fix that. They'll fill it in. They'll say what they want. So you want decision-making, logical decision-making there, and recognition that these high scenarios, whatever they are entirely different in terms of what you need to document. 50% of what we see is routine, no problem. But we all know what these high risks are, and we got to document them much different. To the last slide. Well, 54. 254, there you go. The doctors in court on Tuesdays and Wednesdays. Whole name of the game to avoid being named in the first place. Next slide. So you, as a risk manager, to identify these issues and then proactively ways to monitor, correct, fix, educate, and on avoiding these things in the first place, because we all know where they're coming from, right? And get involved. It ain't, all right? 5 minutes left for questions. Pauline, I'll send it back to you. And thank you.
Mr. Bitterman. This was very interesting and enlightening, and there's a lot of good information here for us risk managers. You should have all received a risk management advisory today from Allied World on high-risk issues in emergency medicine. If you did not receive it, and you would like a copy, please contact risk management at awacservice.com. I think we have a few minutes for some questions, and if you want to send some questions through the chat box, we'll read them over to Dr. Bitterman to answer.
That came out today is focused entirely on chest pain. So this was a single focused intense discussion of chest pain, if you would. So you take that one to get a good start on things. I have a couple questions. Go ahead, Pauline. Or Lisa.
Okay. Now, Pauline, we have a question that came through. You include the importance of discharge instructions and follow-up and listing the family. How information should be given to them, and what do they need to know, separate from their family member being treated? How transparent should we be with the family?
Obviously, you need the patient's permission to involve the family, and most obviously are pretty happy to do that. If that's the case, I involve them as much as possible. Have them in the room for the discharge and explain everything, what's going on, what you're concerned about, what you're looking for, particularly if it's a spouse, and if it's a child, you want to make sure both parents are there as opposed to just one, rather than one out in the waiting room, one in the ED. Bring them both back if they're there. Now, you have to have sensitivity here. If it's a child who's 14 or 15 who came in for pregnancies or sexually transmitted disease or things they don't want their mother to know about, that's fine. You can't tell mom about that sort of stuff. All you say is, look, she's fine. You explain to her what to do. You don't talk to you at home about what as much as she wants to say. Get a little bit of sensitivity to that. But by and large, the more information you can provide, the better.
Okay. Are there areas besides the ones you have addressed that may be less common but still considered high risk for potential litigation involving the emergency department? And should these all be dealt with in a similar manner?
With fever, clearly that's one you have to address. How do we handle kids that present with temperatures over a certain amount? Age-wise, because obviously the younger they are, the more likely to have like sepsis or meningitis. So that's one for sure. Sepsis in adults is another one. High-risk patients, immunocompromised nowadays, steroids or other various medications. A lot of patients with hardware inside, artificial knees, artificial hips. Those have inherent high risk that you might sort of want to think about a little more. If you have fever and someone who's got hardware, they're at risk of having sepsis than people who don't, or those who are immunocompromised. So those would be some other areas: kids with fever, immunocompromised folks, and then the sepsis potential things, which is good attention to vital signs and pulse ox, etc.
Okay, thank you. We don't have any other questions here. If anybody does have any questions that they have after the webinar, please feel free to send them to riskmanagement@awacservices.com, and I'm sure Dr. Bitterman would be happy to address them for you. Dr. Bitterman.
Thank everybody for participating.
If you registered for this event, you will be receiving an email from AWAC Services with the Ashram CE certificate in approximately 2 weeks. Our next program will be on Wednesday, June the 26th from 2 to 3, and the topic is handoffs and transitions, critical intersections in patient care. AWAC Services, I'd like to thank you all for participating in this event and hope you will join us again in the future. Thank you.